And again, I'd like to thank Dr. Mehta and the organizers of Cafe Rentgen for this opportunity to give a talk about preoperative imaging in endoscopic endonasal skull-base surgery. You can hear me okay, right, Dr. Mehta?
Yeah, everything is fine. It's going great.
Okay, thank you.
Thank you.
Um, you see the pointer or, yeah. So I have no disclosures to make. So as a background, endoscopic endonasal transsphenoidal and extended approaches are the standard of care in the surgical treatment of many tumors in and around the skull base, I mean the central skull base. So our topic would mainly focus on the sphenoid bone anatomy, the fundamentals in understanding the approaches, because our knowledge of anatomy is key in helping the surgeons come up with their preoperative strategy and minimize complications. So we highlight the important bony landmarks and neurovascular structures that are relevant to endoscopic endonasal skull-base surgery. So most of the textbooks in at least in the radiology literature would show you 2D cases of CT scan, for example. In this presentation, we utilize 3D volume rendered CT of real life patients to enhance the appreciation of anatomy. So our goals are straightforward. We'll describe the approaches to tumors in terms of endoscopic endonasal surgery, particular lesions in the anterior and central skull base. We'll discuss the anatomy of the sphenoid bone as it pertains to endoscopic skull base surgery. We'll describe patterns of pneumatization of the sphenoid bone. This is also relevant. We'll review the important landmarks, openings, apertures, neurovascular structures related to the sphenoid bone. And finally, we'll correlate the anatomy from an endoscopic view to the endocranial perspective. So this is the gateway to endoscopic endonasal surgery. You can see these nostrils where you put your instrument. We have the turbinates in the nasal septum as your important landmarks. You have the nasal septum. Here you can see it's midline. You have the inferior and the middle turbinate. And from the perspective of an instrument, you can see here the nasal septum. You have the middle turbinate, you have the inferior turbinate, and the choanal arch. So on the sagittal perspective, again, you can see here the floor of the nasal cavity. You have the inferior turbinate and the middle turbinate. So there's also such thing as a superior turbinate, and you can see it here. So the inferior, the middle, and the superior turbinate. And here you can see that it is relevant because it can cover the sphenoid ostium in terms of accessing the sphenoid. You have the sphenoid ostium, and this structure can actually cover the ostium, and they'll have to sort of put it on the side, retract it, so they can see the ostium. Again, on a sagittal image, you can see the important landmarks, particularly the basal, so the inferior turbinate, the middle turbinate, and the basal lamella. So this is the attachment to the anterior ethmoid hair cells. Again, from an endoscopic view, you have the ostium of the sphenoid. You have this sphenoethmoidal recess. You can see here in your instrument the trajectory going towards the sphenoid ostium. You have the sphenoethmoidal recess. And here, again, the nasal septum is an important landmark. You can see deviation of the nasal septum with relative narrowing of this nasal cavity and widening of the opposite nasal cavity. And in terms of instrumentation, they will have to do a posterior section of the they do resection of the posterior nasal septum in order to have a decent surgical corridor where they place their instrument. This is a case of nasal septal perforation. I guess they already you don't see the septum, so it's probably making this the life of the surgeon easier with this particular case. You have the maxillary crest. The maxillary crest attaches to the floor of the nasal cavity. It has an anterior part, the maxillary segment, and the posterior part, which is the palatine segment. Notice that if you follow the floor of the nasal septum, you can follow towards the end of the floor of the sphenoid sinus. The nasal septum, as you all know, is divided into two parts. The inferior part is the vomer here, and the perpendicular plate of the ethmoid bone. Here again is the maxillary crest. You have the maxillary portion, the posterior palatine portion. You have the perpendicular plate, and you have the vomer. And you can see if you follow the floor and angle your instrument, you'll end up in the floor of the nasal cavity towards the floor of the sphenoid sinus. So there are different approaches to treating lesions in the anterior and central skull base, and even in the posterior fossa. You have the approach and the corresponding important landmark. For example, you have the transfrontal approach, and you will have your frontal sinus as your landmark. You have the transcribriform approach. So you have the cribriform plate of the ethmoid as your landmark. You have the transplanum, transtuberculum. So the planum is the flat portion of this segment of the skull base, and this is the planum. And the landmark would be the planum and the tuberculum. And we also have a transcellular approach. For example, if you have a pituitary adenoma, you have the cella. So you have the transcellular approach and the clivus. You have the transclival approach. So you have, you can position the patient depending on the approach. Here you have flat positioning, and the head is extended depending on the approach. And obviously, it's a function of the trajectory of the instrument. Here, the trajectory is towards the sphenoid sinus, and this is correct positioning. Now, if you position the patient wrong, then you will end up resecting the brain instead of resecting a tumor via a sphenoidal approach. So this is good. This is not good. So we'll look at the key bony landmarks. Again, like I said, in the anterior cranial fossa, the flat portion is the planum sphenoidale. You have the limbus sphenoidale, and here are the intracranial apertures of the optic canal. So you have the chiasmatic or prechiasmatic sulcus. You have the anterior margin of the cella, that's the tuberculum cella. The posterior portion is the dorsum, and you have the pituitary fossa. And there are other structures that are obvious to some of you. This is the foramen lacerum, and you have the ovale and the spinosum. So this is a 3D surface rendering. The beauty of this is you can have a 3D perspective instead of a 2D orientation as you would see in a regular CAT scan. This is a real patient, and we just did a 3D rendering on this portion of the skull base. This is the endocranial perspective. So the sphenoid bone, our talk will be mostly focused in and around the structures in the sphenoid. So the sphenoid bone is likened to a bird with unfurled wings. You have the lesser wing, you have the greater wing, you have the body that includes the sphenoid sinus, and you have the pterygoid process. So you have the pterygoid plate and the medial and lateral pterygoid. So here's a coronal view. The important landmarks here, you have the optic nerve impression. This is the optic canal. You have the sphenoid sinus, and you have the superior orbital fissure, the foramen rotundum, and the Vidian canal at the floor of the sphenoid sinus. You also have the inferior orbital fissure here and the rotundum, and it is separated by this bone, and you call that the maxillary strut. So the important landmarks for the lesser wing of the sphenoid, you have the anterior clinoid process. Again, you have the optic nerve impression, the optic canal. We have the superior orbital fissure. And the superior orbital fissure is separated from the optic canal by this piece of bone. We call this optic strut. Again, this is a posterior perspective. You have the anterior clinoid process, and between the greater wing and the lesser wing, you have a cleft here, and that is the superior orbital fissure. And similarly, you have a different perspective. You have the anterior clinoid process. You have the maxillary strut separating the inferior orbital fissure with the rotundum. You have the choanal arch here, and obviously the body that is made up of the sphenoid sinus. So here you have the sphenoid body. You have the anterior margin of the pituitary fossa. You have the tuberculum, and you have the dorsum sellae posteriorly, and you have the posterior clinoid processes. Again, for the body of the sphenoid, it's mainly made up of the sphenoid sinus. At the floor of the sphenoid sinus, you will see the Vidian canal there. And the Vidian canal is a very important landmark because it opens into the foramen lacerum, and it's a landmark for the internal carotid artery. You can see here the internal carotid artery within the carotid canal. So this is what we call a trumpet sign. Basically, the Vidian canal runs along the floor of the sphenoid sinus, and it opens up here. The wider part of the Vidian canal opens up into the pterygopalatine fossa, and the narrower part opens up into the foramen lacerum. So this is the Vidian canal. Is what you call the trumpet sign, because the wider part opens here anteriorly in the pterygopalatine fossa, and the narrower part would open up into the foramen lacerum. So here's your foramen lacerum. On the 2D perspective, again, you can see the pterygopalatine fossa, the Vidian canal, opening up into the foramen lacerum. So we have the Vidian canal, the Vidian nerve here, and then you have the rotundum. So that's V2, and here's the Vidian canal. So we also have the key anatomic relationship of the anterior clinoid process to the internal carotid and the ophthalmic arteries. Here you have the anterior clinoid process. You have the internal carotid artery, and you can see the takeoff, the origin of the ophthalmic artery as it goes anteriorly into the opening, the endocranial aperture towards the optic canal. You have the takeoff of the ophthalmic arteries, and you have the internal carotid artery intimately related to the anterior clinoid process. And obviously, this part, the proximal, the origin, then the proximal segment of the ophthalmic artery would course into the optic canal. So it's another example depicting the relationship of the anterior clinoid process with the internal carotid artery and the ophthalmic artery. So this is the basically, if you have the optic nerve, you have the intraorbital segment and the canalicular segment. So the ophthalmic artery goes on top of the optic nerve at the canalicular segment. And here is a 2D perspective. You see the origin of the ophthalmic artery. Here's your optic nerve, the canalicular segment, and the ophthalmic artery would course over the optic nerve. So in terms of the greater wing of the sphenoid, it's literally it's it's making up most of the floor of the middle cranial fossa. So you have your important landmarks here. You have the foramen rotundo. This is top view from the endocranial perspective. You have the foramen ovale transmitting V3. You have the foramen spinosum transmitting the middle meningeal artery. And there's an inconstant foramen. We call it foramen vesalius, transmitting the sphenoid emissary vein. The emissary vein connects the cavernous sinus with the pterygoid venous plexus inferiorly. So you have the foramen vesalius. We also have the lingular process here. The lingular process separates the petrous segment from the cavernous segment of the internal carotid artery. The lingular process is the attachment of the petroclival ligament, and so it separates the. This is unseen anatomy, but it separates the petrous from the cavernous carotid. Again, here you have the lingual process. On a coronal view, if you just follow the Vidian canal, like I said earlier, it runs along the floor of the sphenoid sinus here. And if you follow posteriorly, you will see this sort of a piece of bone that is projected upwards. Looks like a wedge. And this is the attachment of the petroclival ligament. This is the lingular process that separates the petrous carotid from the cavernous carotid. You can see here on a 2D view, a 3D view. And you have the internal carotid, cavernous, and the petrous segment. We also have clefts of the sphenoid bone. There are two clefts related to the sphenoid bone of importance to endoscopic endonasal skull base surgery. That includes the foramen lacerum and the superior orbital fissure. The foramen lacerum is an important crossroad. Like I showed in the earlier slide, the superior orbital fissure is a cleft between the greater and lesser wings of the sphenoid and carries important neurovascular structures. So this is from the frontal perspective. You see here the superior orbital fissure. And this is the piece of bone that separates the optic canal is situated somewhere there. And this is the optic strap that separates the optic canal from the superior orbital fissure. So this is the frontal perspective. You can see here the orbit. From the posterior perspective, you can see the lesser and the greater wing of the sphenoid. There's a cleft between them, and that is the superior orbital fissure, nicely rendered on this 3D surface shaded display on CT. So just for those for the trainees in the audience, you have the contents of the superior orbital fissure, which you can divide into lateral, central, and inferior. So most of the important nerves, for example, the superior branch of the oculomotor, the inferior branch of the oculomotor, nasociliary, and the sixth nerve is within this central compartment. The inferior compartment would be mainly the inferior ophthalmic vein. The lateral compartment would contain the lacrimal, frontal, the cranial nerve 4, and the superior ophthalmic vein. Again, here on the frontal perspective of the orbit, you can see the superior orbital fissure, and you have the optic canal separated by the optic strap, this piece of bone here. So here's your foramen lacerum. The foramen lacerum is not the quintessential foramen, like for example, the foramen ovale that transmits V3 or the spinosum that transmits the middle meningeal artery. So the foramen lacerum is actually a bony deficiency in the central skull base at the confluence of the important bones, the sphenoid bone, the petrous apex, and the occipital bone, the clivus. So here you can see this area where there's a bony deficiency. So if you orient this image with the prior image, again, you see the Vidian canal running along the floor of the sphenoid sinus here, the Vidian canal. And so here, between the petrous apex and the clivus, you have the petroclival fissure. Between the petrous apex and the sphenoid bone and the lateral part of the sphenoid bone, you have the petrosphenoidal fissure. And here you have the Vidian canal along the floor of the sphenoid. And there's this fissure here that is almost 45-degree in orientation compared relative to the Vidian canal, and that is the pterygosphenoidal fissure. So again, the foramen lacerum is a bony deficiency between three important bones: the sphenoid bone, the petrous portion of the temporal bone, and the clivus, the occipital bone. So important fissures here. You have the petroclival fissure between the petrous apex and clivus. We have the petrosphenoidal fissure between the petrous apex and the lateral portion of the sphenoid bone. And then you have the pterygosphenoidal fissure that runs in about 45-degree orientation relative to the Vidian canal. So all these fissures represent a deficiency among at the convergence of these important bones. And so you have a foramen lacerum. So we'll also look at the sphenoid sinus pneumatization and lateral extension. So depending on the pattern of pneumatization, this may actually make the life of the surgeon easy or difficult. So drilling bone that lacks pneumatization may limit identification of important landmarks and increase risk of injury to underlying neurovascular structures. So the surgeon must be alerted preoperatively of anatomic variants to avoid injury and minimize complications. So you have different patterns of pneumatization relative to the sella. So you have the conchal pneumatization. This is mainly seen in the pediatric population. You can see this thick bone and a little pneumatization of this sphenoid sinus. You have the pre-sellar pneumatization, where this bone is pneumatized, but it doesn't extend to the level of the sella. It just stops short of basically it stops at the margin of the anterior margin of the sella. You have the 2D and the 3D rendering of that. You have sellar pneumatization, where the pneumatization extends at the level of the sella, 3D and 2D. And post-sellar pneumatization would extend beyond the posterior margin of the sella. So here you can see pneumatization of the dorsal sella, again 2D and 3D. So sphenoid sinus can also extend its pneumatization laterally and inferiorly. As you can see here, the greater wing of the sphenoid is pneumatized. So the pneumatization of the sphenoid extends to the floor of the middle cranial fossa bilaterally. And also inferiorly, you have pneumatization of the pterygoid processes. So here's a more like a more focused view. You have pneumatization of the greater wing and the pterygoid process. So we also have the important things to consider. We have anatomic variants. We all know about the anterior clinoid process and the posterior clinoid process, but I'm sure a lot of us don't know anything about the middle clinoid process. So this is analogous to the anterior and posterior clinoid process. You have the middle clinoid process, and these are actually attachments to dural folds or paracellular ligaments. So the middle clinoid process is variably present, and the anterior and posterior clinoid process are always present. So this is important because there are dural folds connecting these processes, and these dural folds may actually ossify. And basically, they need to know that because you cannot just cut these ligaments. They will be acting like a bone, and you can cause injury to the internal carotid artery. So the ligament that connects the anterior and the middle clinoid process is the carotidoclinoid ligament. The ligament that connects the anterior to the posterior clinoid process is the interclinoid ligament. And again, this can ossify and form a bony bridging. So here's an example of a CT.
Sorry to interrupt, Dr. Subson. Can you use the
Yeah,
laser pointer? This is just a bit smaller in size.
okay. How about that? Hold on. How about that?
Yeah, this is perfect. That's great. Thank you so much.
Okay. So here you have the uh, expected location of the middle clinoid process and the anterior clinoid, and basically there's this ligamentous or a dural fold that connects between these processes. This is the carotidoclinoid ligament, and also the carotidoclinoid ligament forms part of the proximal dural ring. That is one of the delineation between the cavernous and the clinoid segment. So if there's a short segment of the carotid that is called clinoid segment, and basically the proximal and distal dural ring delineates the very short segment, the interdural segment. Part of that interdural segment, the proximal dural ring, part of that is the carotidoclinoid ligament. And here you can see the interclinoid ligament connecting the anterior and the posterior clinoid processes. Here you have ossifications of this structure. For example, here you have this bony bridge between the anterior and the posterior clinoid processes. Here it's bilateral. So this is what we call the interclinoid bridge. Here you have a deficiency of the dorsum sellae, but you have bilateral interclinoid bridges. And here you have an example of a unilateral interclinoid bridge representing ossification of the interclinoid ligament. And this is important because some of the surgeries in and around this area, they will have to they will have to do a clinoidectomy. And they cannot remove this. They will just leave it alone. They can maybe trim it, but poses a risk for injury to the internal carotid artery. So here's another example. You have the internal carotid here surrounded by bone. That is what we call the carotidoclinoid ring. And again, that represents the ossification of that dural fold that connects the middle clinoid process here and the anterior clinoid process. So this is a carotidoclinoid ring. And again, as you can see here, the internal carotid artery is surrounded by this ring. And we talked about this earlier. We have the struts. The strut is by definition a piece of bone that separates two skull base openings from each other. So the optic strut separates the optic canal from the superior orbital fissure. Here's your optic strut. Again, this is a frontal perspective. It's an endocranial view. And you can see here the piece of bone that separates the foramen ovale from the vitrosphenoidal fissure. This is the mandibular foramen. And here earlier, you saw the piece of bone that separates the inferior orbital fissure from the foramen rotundum. That is the uh, maxillary strut. So you have a maxillary, the mandibular, and the optic strut. These are the struts. These are pieces of bone that separates two openings from each other. So we also have to recognize important anatomic variants that may pose hazard during endoscopic skull base surgery. And we saw examples like the interclinoid bridge, the carotical clinoid ring. We have attachments of the intersphenoid sinus septum. For example, here is your optic impression, the optic canal. The base of the optic canal, you have this accessory intersphenoid sinus septum that attaches to the base of the optic canal or the optic nerve impression. And this is something that they want to know because if they remove this septation, they can actually cause injury to the optic nerve, or this can bleed into the optic canal, and you will have some sort of ischemic neuropathy from compression. So here's another example. Here's your intersphenoid sinus septum attaching to the base of the optic canal of the or optic nerve impression on 2D, and here on 3D. So here you have the carotid canal protruding into the sphenoid sinus. Again, here there is this septum that attaches to the carotid canal. Here also you can see the septum attaching to the carotid canal. We have also another variant. You have dehiscence of the foramen rotundum. You can see here that the V2 segment is protruding into this pneumatized sphenoid sinus. We also have bilateral dehiscence of the optic canal, better seen on 2D, but you can also appreciate here on the 3D rendering. There is a lack of bony coverage, expected bony coverage at the inferior aspect or the floor of the optic canal. So this is all bony dehiscence. And again, this is a hazard because it can cause complications, visual complications during surgery related to optic nerve injury. Another example of the sphenoid sinus septum attaching to the carotid canal here on 2D and on 3D rendering. You also have a carotid protrusion to the sphenoid sinus. So you can see here, there's lack of bony covering of the carotid canal and the walls of the sphenoid sinus. As you can see here on the AP, you have the coronal, also on the sagittal image. So they need to know this because normally the pre-op is very important to avoid injury to the ICA. Here's another example of an anatomic variant. And you can see here a persistent trigeminal artery. And you see the medialized course of the persistent trigeminal artery penetrating the dorsum sellae here on 2D. And you can see also 3D rendering. So there's a medialized course of this vessel. And yeah, they just need to know this variant anatomy if they're trying to do surgery within the sella or the paracellular area here. It's another vascular anatomic variant. You can see the medialized course of the fetal PCA coming from the ICA here. And the artery both coursing over the dorsum sellae. But importantly here is the medialized course of the fetal PCA. So we have endocranial and endoscopic perspective. You have the view from the endoscope, and we're trying to correlate with the endocranial view. You have the sella, the usual landmarks, the sella, the optic nerve impression, and you have the course of the carotid arteries. You can see here the from the endoscopic view, you have the uh, optic optic impressions. You have the optic protuberance, the carotid protuberance, and you have the tuberculum, and you have the pituitary fossa. What's important, these are the cardinal landmarks, the carotid, the optic protuberance. You have the pituitary, and you have the medial and the lateral opticocarotid recess. So here, this is the corresponding area where you have the, this is the correlate to the endocranial perspective of the optic and the carotid protuberances. You also have the clival recess, and you have the tuberculum. So this is the area corresponding to the chiasm and the tuberculum recess. That's a sort of simplified version of that. You have the carotid protuberance. Okay. You have the optic protuberance here on this schematic. So optic and then carotid protuberance. So at the junction between the optic and carotid protuberance, you can see the medial opticocarotid recess, and you also have the lateral opticocarotid recess that corresponds to the base of the optic strut. So we were talking about optic strut earlier. From the endoscopic perspective, that corresponds to the lateral opticocarotid recess. You have the again landmarks from an endoscopic perspective here. Just basically showing you the optic protuberance, the carotid arteries, and the clival recess. So that's the sellar face, that's the sellar floor, clival recess, the planum, you have the planum. Again, a tuberculum strut corresponding to that view, and you have the carotid protuberances. So these areas are basically divided into, I mean, they form somewhat of a stair-step pattern. For example, here, the planum, you have the tuberculum, you have the sellar face, you have the sellar floor, and the clivus here. So these areas correspond, you can divide it into upper clivus, the middle clivus, and then lower clivus. Here, you can see the instrument into the planum. So transplanum, You have the cellar face, and you have the clival recess. So here's a case. You have a 62-year-old female deteriorating visual function in left eye over several months. Went to the ED, they got a CT and showed a cellar and suprasellar mass. Patient had bitemporal visual field cup, left more than right. No diplopia. Here's the eye exam. We have a dense temporal visual field cup, visual acuity 20/70. On the right eye, you have a subtle loss in inferior temporal quadrant. At the far periphery, visual acuity 20/30. So the summary of this case, you have a predominantly, say, complex mass, and you can have you see the pituitary, you have the mass, you have the chiasm that is effaced, partially effaced, and you have the carotid artery flow voids. And again, here you have the mass in relationship to this pattern that you see here: the planum, the tuberculum, the cellar floor, and the clivus. This is the mass in relation to these areas. And here you have an endoscopic. This is the intro video opening of the dura. So this is where they're working on. This is the area of the pituitary. And you can see here the optic chiasm. And they're trying to deliver the mass. Owning the different endoscopic surgical approaches to lesions in the sella and paracellar regions. Paracellar ligaments that attach to the anterior, middle, and posterior clinoid processes may actually ossify and form interclinoid ridges and corticoclinoid rings, as you saw in my slides previously. Resection of these structures are avoided during surgery to avoid carotid artery injury. The surgeon must be alerted preoperatively of potential is crucial. And endoscopic landmarks can be correlated with the anatomy from the endocranial perspective. The important recesses include the MOCR, LOCR, which correspond to the lateral aspect of the tuberculum and base of the optic strut, respectively. Special acknowledgement to my